Hey everyone, welcome to UC Max Live. I'm Britt Guest.
And I'm Scott Kobner. Welcome to the Halloween edition. Britt,
Woohoo!
What are you dressed up tonight as?
I'm a cat. Scott Kobner. What are you?
I'm birth control. I told you it was a good joke. She didn't want to go with that one live. I thought it was pretty good.
I apologize. I feel like I should apologize right now.
Obviously, I'm Jean-Luc Picard. I've got the hairdo. Come on. Star Trek, my favorite series.
I get it though. I get it.
I love it.
All right.
What do we have for tonight?
For this show, well, let's talk about headlines, bottom lines, and really the bottom line is we're going to ASAP.
Absolutely. It's going to be an amazing time. Please come join us. We're going to have booths for both UC Max and for EMRAP, and we also are going to have a 3-hour performance lecture piece that is on October 9th. It's from 2:30 to 5:30 Eastern Standard Time. I guess it's now just Eastern Time, whatever.
Eastern Time.
In the Terrace Ballroom. That's where you can find us. Please, it's going to be a huge seating. Come join us. It's going to be a great time. Britt, what's going to go on in the booth? I know you've been making quite an experience for
people.
The
booth is going to be so cool. We're basically, well, there's two booths, right? We've got the EMRAP booth, we've got the UC Max booth. At the EMRAP booth, we're going to recreate the studio. We're going to kind of create this experience so you can see what we do behind the scenes.
You can get all your lame jokes in person.
Which is mostly nonsense. All right, so for this show, we've got some awesome faculty with us. We have Dr. Josh Russell. He is the editor of our UC Max podcast. We've also got Dr. Sean Nort, who has so many titles, I can't even remember all of them. He's an ER doctor, he's a toxicologist, he's a pharmacist, he's basically everything.
All the things. He pays $40,000 a year in board certification fees. It's true. Very true.
We also, of course, have Mike and Gita with us virtually, of course. And then what's this little QR code thing here?
Yeah, we got a QR code. You know that if you're coming from the urgent care space, you might be interested in actually subscribing to the UC Max podcast. There's going to be links and stuff down in the doobly-doo below. You love it. Join, subscribe, like, comment, all that fun stuff. But if you scan this QR code, it's going to take you to our page. And, you know, in honor of Josh Russell here tonight, we got the promo code JR to the max. Get a discount. Be great. Type it in. Have a good time. Yeah, JR to the max. UC Max. He's here. He's with us. He's maxing it out. It's going to be a good time.
The jokes will go on all night, people, I promise. All right, so our first segment of the evening is images of the evening. So let's turn to that.
It was all a dream. It was all a dream.
All right, welcome to Clinical Images of the Evening. It's the Halloween edition. We're 28 days early, baby, but we're still getting all the candy, all the goodness. All of our images this evening are going to be related to Halloween-related incidents that you might encounter on your next urgent care shift. So the first that we have tonight is looking like this. You have someone that's come in after having too much candy corn. You love it, you hate it, they get really hard and stale, has a bunch of dental pain. You open their mouth up, and this is what you find hanging out there above their maxillary premolar. What do we got going on? We're going to turn right now to Mike and Gita to hear what their take is on this image.
Well, this looks like it really could be a dental abscess. And so, you know, candy notwithstanding, this is not something that seems like it would be that fun. And so it looks like if you were to put your fingers in there, which you might want to do to feel around, you might be able to find an area of fluctuance that might require an actual incision and drainage. And so I can imagine if you saw this person and you could see their whole face, that they might have facial swelling and edema, and you'd have to go into the mouth and see, like, where is there a spot that I might be able to drain, or is this something that I'm just going to treat with antibiotics? So assuming that there is some place that you could incise and drain, I will usually opt for the dental block. I think we're going to talk about a dental block or how to do dental blocks maybe later on in the program. I mean, depending. I mean, you can always kind of get a feel, but like people are usually really apprehensive, and it's nice if they don't feel much. And I usually do the dental block because I'm a milker. Like, I really like to just get in there and, like, if I can squeeze all the pus out, like, which is not comfortable, but it's very satisfying for me. And it's also very satisfying for the patient when all the pus is out of there. And so if they're good and numb, like, to my mind, I feel a little better about doing that. That's all.
And in addition to maybe helping during the procedure, although if it's a big bulging area, maybe they wouldn't feel it too much, but they certainly are going to still have some discomfort after that. And the dental block can certainly help with that while your antibiotics are kicking in. Love the plan. And the next time I get a dental abscess, Gita, I'm coming to see you.
Yeah.
So yes, we have the painful, the awful dental abscess. You know, a lot of times people call these periapical abscesses, which sometimes is a misnomer because that's when the infection actually involves the pulp. On the real outskirts, most times we see gingival abscesses or periodontal abscess, which is kind of like a catch-all term for things that aren't super superficial. And that's totally right, Mike and Gita. Like going after this thing can provide the patient with a lot of relief, but pain is going to be the huge symptom that they come in with. And we're going to do a whole little talk in Procedures of the Month, how you might want to address this with the dental block. So I know there's some questions in the chat, like what type of block you would use. But one of my favorite tips is actually taking some lidocaine, 4%, 5% ointment, and kind of just throwing it on there even before you do the block. Give the patient instant pain control. And if procedures aren't in your wheelhouse, because you haven't watched our segment yet, you're going to be able to give that patient relief right off the bat. Of course, make them feel better. Tell them to eat less candy corn next time. See their dentist. All right, we got our next image up. Really excited about this one. So we have somebody who just was really excited after their trick-or-treat bag, jumped in there, and you know, they had a Nutter Butter, and they have a terrible allergy to peanuts, and they didn't think that peanuts was the thing in the Nutter Butter. This is the rash they come in with. It's super, super itchy. They look kind of awful. What do you think could be going on, Mike and Gita?
So when I walk in the room and I see this rash, the biggest thing that I think is relief, because I'm walking in the room thinking, could this be petechial? A little bit more hard to diagnose and find an actual etiology and a management strategy, or could it be vesicular? And I'm looking at a rash that looks urticarial, but the most important thing is to go and press on that rash. I press on the rash and it blanches. And then the other super important thing of the exam is to look at the oropharynx, right? And make sure that there's no evidence of any airway impingement, drooling, stridor, edema in that area. Once we've established that, Gita, we're really moving pretty quickly towards our management strategy.
Yeah, and so for managing urticaria, if you're simply urticaria, the first thing you're going to want to know is, gosh, how do we prevent it from happening? How do we keep it from going on if this is a continued offending agent that you're allergic to? So you're going to cover a lot of that in the history and see if you can figure out what caused this rash. Sometimes you can't get to the bottom of it in the urgent care in your history. That happens all the time where you're just sort of like, I don't really know, but we're going to treat your symptoms. For me, the first thing I reach for now these days is oral cetirizine, Zyrtec, which is over the counter. You can also do a prescription. Allergists will give up to like 40 milligrams, even though on the box it'll say 10 milligrams. So you can tell them you can start at 10 milligrams. You can double it if you need to. I always give them what not to do, like don't take hot showers, try not to scratch. It's going to make those things worse. And I'm going to ask you, Mike, steroids, yay or nay? Because I think lately I've been thinking nay.
I 100% agree. And, you know, like in general, steroids are fairly benign, but the fact is we can certainly have people that get insomnia or weight gain or a steroid psychosis. So I'm doing the exact same thing as you. Not only am I reaching for an antihistamine, but I love the fact that you're going for the non-sedating antihistamine, because literally having allergies when I was a kid and taking diphenhydramine and being like totally exhausted all the time was no way to go. And it doesn't affect everyone that way. Kids can have a paradoxical reaction. They could get actually more hyper when they take that diphenhydramine. So yeah, I think the non-sedating antihistamine is the absolute way to go, as well as the most important thing, like you just said, is to make sure that they've removed the offending potential inciting factor if we're able to localize that, which in my experience is about half the time we can figure that out.
Thanks for that great discussion, Mike and Gita. You know, we're going to TOTS for a second here and throw out the script. If you guys can guess what Mike and Gita actually are for their costumes in the chat, we're going to give some kind of Apple product. I think we've been debating it a little bit today. So we're excited to hear what you guys have to say, what we should refer to them as in the chat. But urticaria, super, super common. And I like the little debate in there about, you know, how you should treat it in the setting. But I think a really important takeaway for urgent care providers and any clinicians anywhere is just really being careful about making the distinction between just a simple urticarial eruption and someone having full-on anaphylaxis, and know that obviously that's going to change your course of treatment and where you need to refer and or transfer that patient to. All right, so for our final image of the evening, we had someone who got a little too excited carving a pumpkin, got a little too excited with that little plastic saw blade file that's in there, and ends up coming in to your urgent care with a really nasty looking finger. this is what they come in with. Right now, we've already done a nice job of dressing it up, putting a little tourniquet on it, but it was bleeding, looks pretty awful. Let's hear what Mike and Gita have to say about what they would do with this.
Okay, so these injuries, when they come in, can look kind of scary because they're usually bleeding all over the place. And then whatever dressing this person has put on it at home, like the paper towel dressing or whatever, you try and pull that thing off and all of a sudden it's going to start bleeding again. So hemostasis, I feel like, is the first order of the day. And so you're going to want to tourniquet this. I think in this picture, they're using a T-ring, which is a commercially available finger type tourniquet, which I do think actually works pretty well. I'm not endorsing anything, but you really want tight hemostasis on that finger. And then once you've got sort of this bloodless field where it's not oozing all over the place, then you can inspect it more. Make sure you don't see exposed bone, which is another beast that you would have to think about. If it really is just the tissue, your main goal then is how are you going to make it stop? So I've learned a new trick, but Mike, I want to know what you do.
Once we have the bleeding stopped with these fingertip injuries, it's really going to be a matter of that fingertip healing by secondary intention. We're going to want to inspect the nail, of course, and see what is affected with that. And we can't really get a good visualization of that in this picture, which is totally fine. But in the end, I'm not doing antibiotics for these. I am putting this thing with like a non-adhesive type of dressing, like even like a Vaseline gauze would be an easy way to go, but there's other ways to do with that. What are you doing with these management-wise, Gita, assuming the bleeding is stopped?
So one trick that I've learned recently, and I did get to try it, was if you can get that field completely dry, you can use tissue adhesive glue, like, brand name Dermabond. But I hadn't done that before. I think it's really important that you get it super dry, and you do have to put on a number of layers of the glue. But the last time I had this, I had a really tight tourniquet, and I put on layer after layer after Dermabond. And there was definitely this moment of like, oh my God, I don't know what's going to happen when I take this tourniquet off. But it held great. And then when it was like completely dry, that person could put on, a splint to protect it, and then a dressing around the splint so that the dressing didn't actually stick to the Dermabond itself. And it worked great.
Yeah, I have not done the Dermabond. I think it's a really interesting consideration. But again, we need that completely dry right before you put it on, or else it's just going to come straight off.
It's going to be a bloody mess.
Even more of a bloody mess than this this hairdo that I have going on right now.
Thank you so much, Mike and Gita. I love all of your guys' answers also in the chat. We're going to keep that rolling for a little bit because it's pretty funny to read through what some of these guesses are for who they are. We've had the same discussion here, so it feels like we're not crazy people. Anyways, for these finger avulsions, which of course is what we're talking about, a finger pad avulsion, they can be really tricky to treat sometimes. And as Mike and Gita alluded to, they bleed so much, so many capillary beds there. And really the primary thing we got to do is get the bleeding under control so we can assess if there's any bone that needs to be rongered by somebody else. I'm certainly not doing that in an urgent care environment, or how to repair it if there's something else that needs to be repaired there. One tip that I've always found to be super helpful is taking a little container and putting some lidocaine with epinephrine in it and just having the patient dunk their finger into it, having it hang out there. Just that topical application of epinephrine can really cause that vascular constriction that you'll need to get a nice clean field. In addition to putting on that finger tourniquet, if you don't have this fancy finger tourniquet that we featured here, I've certainly never worked in a place that had that. You can always just use a regular tourniquet and a pair of hemostats or a Kelly. And the kind of ice cream cap of skin adhesive glue on the top after you got that field dry honestly works wonders, especially for making the patient go home happy and knowing that that wound is protected and clear. So those are our clinical images for the evening. Stay tuned for our next segment. What's the evidence?
Yeah? Girls into doctor right away.
Oh, we're on. Sorry. We are back, and we're going to be doing What's the Evidence? So I really like this segment because I think there's a lot of things that we do that we're just so used to doing because that's the way we do it all the time, but we never really think of, is that the best way? Is there really evidence behind choosing that medication? So what I want to focus on is migraines and how we manage and treat migraines. Josh, or should I refer to you as Ken? What do you prefer today?
I will respond to either tonight.
Okay, all right. So Josh, as our urgent care expert, I want to talk to you about migraines. Now, a lot of people are going to come in and say they have this horrible headache. How do we decide, is this really just a headache or a migraine? How do we differentiate?
Yeah, such an important first question. And I have a headache from this bandana right now, so it is not a migraine.
That's probably a tension headache.
It is not a migraine. Thank you. But it is a bad headache, and I might describe it if I were a patient as a migraine. But migraine has a specific definition, and it actually is helpful to think of the root word migraine comes from hemicrania, so it's generally half of the head. But what's really the distinguishing feature is this is not a new problem for people. It's a chronic problem and it is a recurrent problem. So what you want to hear from somebody, and most assuringly, is that this is like prior headaches. But there are formal criteria that are on the screen here, and they're put out by the American Headache Society for the definition of what constitutes a migraine. And people have to have at least 2 of the 4 following. So it needs to be unilateral, pulsating in quality, pretty severe, and then aggravated usually by things like physical activity. And then again, it has to be recurrent. So if you've had this 5 times, then you have migraines. And you can see unilateral is just one criterion. So you can have bilateral migraines, but more commonly, it's a unilateral headache.
I think that's my favorite thing that people say is this feels just like the headaches I've had before, because we're not going to go into all the red flags of headaches, but they're, if they're fevering, if there's trauma, if there's nuchal rigidity, I mean, obviously we got to think about other things, but the second they say this feels just like the migraine I had last year, you're like, okay, cool, this is a migraine. Speaking of kind of the descriptors people might use, or how we would describe a migraine headache. You mentioned this, or we had talked earlier about this pound mnemonic. What are the components of pound?
Yeah, so this is a mnemonic that you can find in the study that we referenced. It's from the American Family Physician in 2018. But this is sort of a handy way to remember because it's a descriptive term of how people describe these headaches typically. And the more of these features that patients have, the more likely it is to be a migraine. So pulsatile, like we mentioned, 1-day duration or less. If it's unilateral, if they're having nausea or vomiting, certainly common, and then very disabling in intensity. But if they have all of those, the positive likelihood ratio that this is a migraine, or even 4 out of the 5, is 24, which is, any likelihood ratio that's positive above 10 is pretty strong predictor.
So if they have all of the pound criteria, like this is a migraine.
Exactly.
Okay, so let's talk about first line treatment of a migraine. Let's say you've got someone coming into urgent care and they look pretty uncomfortable. They're walking, they're okay, their vital signs are stable, but they're uncomfortable. They're wearing sunglasses because they're just so sensitive to light. What is kind of your first line treatment approach for this patient?
So migraine treatment should be tiered based on the severity of the symptoms. And a lot of these things patients can and arguably should take at home, but it's misguided if we assume that they have. So
many times you're just like, so did you do the basics, like the Motrin and the Tylenol? And they're like, oh yeah, I took 500 milligrams of Tylenol yesterday.
Right.
Like, okay.
So important. You have to verify that they're taking these things and that adequate doses. But the first line treatments for migraine are not surprising. These are the things that are sold over the counter. Acetaminophen, 1,000 milligrams is usually the strength, up to 3 times a day. There are combination products. These are typically acetaminophen plus aspirin plus caffeine. And caffeine actually acts at these adenosine receptors in our brain and seems to have some effect on the pathophysiology of migraine. And then finally, good old NSAIDs, which would be ibuprofen or naproxen. And the study that we have here about the review posted or published in JAMA from 2021 showed that from the studies that they've reviewed, there's really no difference between the efficacy of an oral dose of ibuprofen and an intramuscular dose of ketorolac. Now, that may not be true for every patient, and certain patients have a strong belief in certain cases that the ketorolac is what they need. But if you look at all of the evidence, it doesn't suggest that there's any benefit to the intramuscular injection.
And I think maybe what you're referring to is that some people just think it's gonna be better if it's an IM injection for some reason, but really we just see that if they can take oral is just as good.
Exactly.
Okay, so assuming that this person's already taken the ibuprofen, the Motrin, the Tylenol. Talk to me about triptans. Like, it's not something I normally prescribe, but is this something that you see people already coming in on? Is this something that you're prescribing in urgent care? And if so, who would you give a triptan to?
Yeah, that's a great question. So there's a lot of evidence behind triptans. Sumatriptan is the most studied. It was the first triptan on the market. It's commonly known as Imitrex. It comes in a lot of different forms. But the number needed to treat, then this is also from the American Family Physician Review that we have in the show notes, for the use of this 6 milligram dose of sub-Q sumatriptan is 2, really, for migraine relief, which is about the best number you can get short of 1.
That's really impressive.
Yeah. So I do use triptans, and patients are also using triptans, so it's nice to know that triptans are safe with NSAIDs, and they actually work synergistically, it seems.
Okay.
But you do want to keep in mind that patients with vascular disease, specifically coronary disease, you really shouldn't use triptans because they can induce coronary vasospasm, and some patients will get usually self-limited chest pain, but still not something you want to deal with when someone comes in.
They already have a migraine. You don't want to give them chest pain on top of it. Probably not a good look.
Yes.
Okay, so another medication that I want to talk about are these ergots. I mean, I see people on them. I never prescribe them. Should we be prescribing them, or what do we really need to know about them when somebody might already be on them with a history of migraines?
Yeah, great question. So ergots are the first prescription or drugs that were developed for treatment of migraine. They're over 100 years old, and there's a lot of different flavors, just like triptans. But they have a lot more side effects than triptans in general, and generally, I don't prescribe them. There's no evidence to say that this class is better than triptans, so we really I don't think should be prescribing them based on the review of the evidence that we have right now for migraine treatment. But patients may come in taking these. So the important thing to remember is to get a history of not only what they've tried, but also any prescription medications they're getting for their migraine, because this also can induce vasospasm or vascular problems. So you don't want to give a triptan in anybody who's taken any kind of ergot within the last 24 hours.
Right, because then you're going to get basically a lot of vasoconstriction there.
Yes.
Okay, so another class of medications I want to talk about are antiemetics, right? Because a lot of people with migraines have nausea, vomiting, or just for the headache in general, we're treating them with some sort of antiemetic. There's so many different ones to choose from. Is one better than the other? Are they all kind of considered similar, or is there a preferred antiemetic that we should be reaching for?
Yeah, go to the next list there. So this is a list in the review article in JAMA on acute migraine treatment of the different agents that have been compared. Some of them head-to-head, some of them to placebo. They've done pretty much every permutation you can imagine.
We've studied this a lot.
Of these antiemetics, and some of them are not classically, nausea medications, but these are all injectable medications that have been studied for the acute treatment of migraine, and the short answer is they're all equally effective. So what you want to do is think about what do you have available in your urgent care, because I guarantee no urgent care is going to have all 6 of these.
If you have droperidol in your urgent care, I am very jealous because I don't even have that in my ER.
Exactly. So probably the one you're going to see most commonly is metoclopramide or Reglan, prochlorperazine or compazine, probably second most. And those are both reasonable options. Promethazine or Phenergan is also commonly available. The thing to remember about that is that it's quite sedating among these.
Yeah.
So unless you want someone snoozing in a room for a couple hours in your urgent care, you probably want to steer away from that. But because these are all equally effective, I just ask patients, because again, this is a chronic and recurrent problem, what have you gotten that's worked for this in the past? And pick that, because they tolerate it and you know that it works, and that's really all you're looking for is symptom relief.
Okay, amazing. I want to talk about a few other medications, kind of rapid fire here.
Yes.
Benadryl.
Yes.
Do you ever use it? And if you use it, are you giving it with compazine? Are you giving it prophylactically, or should we just avoid it in general?
All good questions. In general, it was great for urticaria, like we talked about earlier, but for headaches, it doesn't do anything in addition to the antiemetic itself. So the theory behind its use in a lot of cases is that it's going to prevent some of these EPS reactions. And that first of all doesn't really bear out, but second of all is not going to treat a lot of the things that we were talking with Sean Nort earlier. Like the akathisia doesn't really respond to that even. So again, very sedating. It's going to keep them in the urgent care longer. It's not helping their headache. So no, I don't use it, but it is available to have on hand if you're finding someone who's having true dystonia, which is, you know, torticollis or something like that.
So we're not using it to treat the migraine.
No.
We're not using it to prophylactically to make sure those patients don't develop that really uncomfortable crawling out of their skin, gotta go, even though it will make a short stay in your urgent care. It's not nice. But if people develop those symptoms, this is a handy medication to have and give only if they develop those symptoms.
Exactly. And those symptoms of EPS are related to the dose, the route of administration, and how rapidly you give it. So if you're giving it intramuscular, it's less likely to cause these symptoms. And if you're choosing sort of a lower starting dose, that's a better strategy than giving the Benadryl.
Okay, next rapid fire medication, magnesium.
Magnesium.
Should we be giving it?
So, no, we shouldn't generally not be giving magnesium. It is helpful in rare cases when it's migraine with aura, which is only about 15% of patients with migraine have aura. If you don't have aura, it's of no benefit, and it also has to be given usually slowly over a long period of time in an IV, and many of those things are not feasible for urgent care settings. So magnesium probably should be off your list of migraine medications in urgent care.
All right, last one, probably the most controversial one. You've got someone coming in and they're like, I'm on the triptan, I've been taking the ibuprofen, I've been taking the Tylenol, I'm doing all my things, my headache's horrible, nothing's making it go away, can I please get some sort of opioid, whether that be a shot of morphine, a pill of Norco or Percocet, like just give me something. Do you ever give opioids?
Again, no.
Okay.
So let me expound upon that a little bit, because there is clear guideline from the American Headache Society and the Choosing Wisely campaign from the neurologists that we should avoid opioids because they make the headache worse when they wear off. So people get rebound headaches. Second of all, the patients, if they're not responding to any of those things that you just mentioned, my first thought is not, what can I do to make this headache go away? It's, is this a migraine? Because really, a headache that's not responding to any of the migraine therapies probably warrants further evaluation. It's not following an urgent care pattern of headache treatment.
Yeah, I think that rebound headache, I didn't really think that was a real thing, and the more I treat migraines, and there's the few times I have given opioids, I mean, that's a real thing. They truly get a little bit of relief, couple hours, and then the next thing you know, they have not only another headache, but oftentimes a worse headache. So you kind of just made the problem worse.
Absolutely.
All right, so we talked a lot about the do's, the don'ts, but Josh, what I really want to know is what is in Josh's migraine cocktail?
Well, so for my patients, I again go to the principle of a cocktail is if someone's coming over, I don't serve them what I want them to drink. I serve them what works for them, like what their choice is. So the same thing is true. Like these people have had headaches like this before. They've probably been seen in urgent care or an emergency department for this before. So I just ask them what's worked. This is my tiered approach. If someone has come in and I'm really convinced it sounds exactly like a migraine, but then they've never had any injectable medications or treatment outside of just taking over-the-counter medications. So again, starting with an NSAID and acetaminophen. If no relief with that, then adding the triptan. And then metoclopramide is the antiemetic that I like to use. 10 milligrams IM is a good, reasonable starting dose. And then dexamethasone we didn't really talk about, but that's the IV form can be given orally, and it's equally effective. So you're not giving them, whatever Tom said, 4 or 5 injections. But that steroid is not for this immediate headache, but it does have a number needed to treat of 10, which isn't terrible for preventing the headache from coming back, which, you know, that's not our problem, but this patient is going to go have a life imaginably after they leave, and hopefully that doesn't involve the headache coming back and, you know, feeling like they didn't get anything out of their visit.
Amazing. Okay, so I love the cocktail. I think also keeping in mind, this is not the patient's first rodeo with this headache. They've experienced this before and really working with them to see what's worked best for them in the past. All right, so that concludes What's the Evidence. Thank you so much, Josh, Ken, whatever you want to go by. The next segment, we are going to go back to one of my favorite segments of Wound Care Kitchen.
Sean, you have the best costume here tonight.
Hey, welcome to Treehouse of Medicine Horror Edition. Bam!
Here's the problem.
Wound Kitchen.
In tonight's Wound Kitchen, customer wanted a medium rare, Sean. What did we do?
Well,
We burned it.
we burned
We
it.
burned it. We're talking about burns.
We are talking about it. In fact, we were just down in the UC Max kitchen making some Squid Games honey cookies and nearly had burns on both of us, and we almost weren't here. But we are here, and we're bringing to you some BAM wound care knowledge.
Absolutely. Absolutely. We're so pumped for this. So let's talk about it. So urgent care patients coming in, adults, most commonly they're going to be coming in with some sort of thermal burn.
That's right.
Hands, arms, most commonly seen in the urgent care. Less likely you're going to see something chemical or a kind of an immersion type burn. Very, very common. How often are you seeing these types of patients? Where the burns are?
Yeah, fairly. I mean, I would say at least once or twice a month where I work. I mean, I don't work exclusively in urgent care, but they are not uncommon. Then you mentioned the adults, and then remember little kids, very often little scald injuries, right? Because they pull those things down, or so those are kind of the different patient populations, right, that you can see.
Absolutely. And I think there's a lot of myths out there about what to do to treat these types of injuries. And I don't know, what's the... I think the craziest thing I've seen is a patient that's come in with almost half a tube of Colgate whitening toothpaste applied to these burns, because that's like kind of the myth that's out there, how they should be caring for these wounds at home. What are some things that you might have seen patients come in with?
Yeah, I've seen a lot. I mean, things like aloe vera. I mean, things that are a little bit more follow, maybe some stuff. But everybody's seen the toothpaste.
Everybody's seen the
toothpaste.
And
I've never seen such bright white wounds as that. Just a Colgate smile on their hands and arms.
So, what are the things that you're thinking about actually putting on this burn? So let's say you have a patient that has a small, let's even say less than a few millimeter blister that's been unroofed already before they come in. We'll talk about that in a second. And they're like, what can I put on this to go out with, doc? They might have heard of this cream before.
Oh, all right.
I see, you're ready.
I already see you growing. Give me that cream.
Yeah, let's see what we got. What is this?
Who does not know the blue tube of hell known as silver sulfadiazine? And I'm going downtown. 3-point shot. To the bin or to the floor.
Nailed it.
And so that really shouldn't be, and we were all ingrained
with sulfadiazine
to use sulfadiazine in there. And what it does is it actually covers the wound. So if this was a patient, and we will get into who needs to go to a burn center, but you're just causing a lot of pain because it's going to need to be removed. It occludes them being able to assess, and it actually causes endoepithelial damage. And so it impairs wound healing. It's not great.
And even though this is a prescribed medication, I've certainly seen patients come in after someone has a tube of it laying at home, or another physician, their primary care doc called it in, recommended that they get it checked out, and hey, it's sticking to my wound, the wound's not healing, so something you wouldn't recommend. That's something I don't use at all, and you might still see it out there.
Yeah, so absolutely, so that's a no-go. But I want to know if it's soon after, you have to cool the wound. Do that best by having them go to the sink and just run it under cold water. You can use cold saline compresses and things, but that's not going to cool it like ongoing flowing water. So assess if this is a new one. We're not talking about chemical burns, but the same thing with chemical burns. You have to decon them, right? Because the longer it's in contact, the longer it's going to burn. So that's the first thing that I'm going to do.
100%. And I think it's important to put in context here. We're talking about pretty minor body surface area wounds. Like, this is not a situation where you're like whipping out the burn gown, the burn sheet. So just plain old tap water, that's cool, is totally safe, totally effective to clean this wound and provide some pain relief. I mean, everyone's burned their hand in the kitchen before, burn themselves on the Uber Eats bag if they don't cook, and they know to just do that and get some pain relief.
Yes, because when you have that area, it releases a lot of vasoactive substances, cytokines, other pain mediators. So absolutely, nonsteroidals are really good. You can use acetaminophen, and if you have to, even something more than that. But pain control, absolutely, because you need to clean it. You need to really assess what you're dealing with, and where it's located, right, is a huge thing.
Absolutely. So the first thing we do is get the gunk off that might have been put on it before coming to the urgent care, whether it's sulfadiazine, which we don't recommend, toothpaste, aloe vera, put it under some cool water to really make sure that it's clean. We got some initial pain control, and then assess what this burn actually looks like. We're going to put up on the screen now, these are the recommendations you can find in CorePendium, assembled in other areas, for where you should transfer patients, or when you should transfer patients rather, to a burn center. Now, there's a big asterisk here, Sean, for all of these criteria, because you have to remember, when people are publishing criteria of when to send something to a burn center or refer it there, like, these recommendations are not made lightly. We want to make sure that we're going to be very conservative. We want to make sure that all patients are taken care of, and obviously people with litigation in mind are publishing some of these criteria. So you see things on here like face, hand, feet, those types of things that get burned. Where are people getting burned when they're cooking? It's gonna be on their hands, right? It's gonna be on their upper arms. So these aren't hard and fast rules to send somebody emergently to a burn center, but it's to remind you that in these very sensitive areas that the person should follow up long-term with a burn specialist to ensure proper wound healing. Now again, like the hands, a small blister on the finger, a small splash burn from some hot oil, this is not something that if they come into your urgent care, you're gonna need to refer that person to a burn specialist, but in a functional area of the hand, over your DIP, your PIP joints, those places, you do wanna make sure that those wounds are eventually followed up so that they heal well and there's no functional deficit.
Yeah, and so Scott, you said, and right, we can talk about the degrees of burns, right? So you first, second, we can go into the thickness, and then third. Third is basically cooked. You cannot uncook an egg. If it's cooked tissue, that is third degree. Most of them are gonna be first degree, that's a sunburn. If it looks like a sunburn, and when you say face, I've seen so many patients over my career who've been at the barbecue and did a big lighter fluid and gets a big burst, and then they might have a little singed eyebrows or something like that, but it's basically a sunburn. They do not have to, as long as there's no airway stuff, they don't need to go to a burn center. So as you correctly said, you have to kind of assess the patient that you're dealing with.
Totally.
But if it is anything, particularly circumferential, or if it's over joints, particularly, we always worry about the hands. So, and then you can watch them for a while, because sometimes you'll see, even at the time that you're watching them, they will blister up. And then you'll say, hey, I maybe went from a first degree into a second degree, and that's usually a partial thickness with just the blistering alone.
Absolutely, and I think this is a great opportunity. If you're ever unsure, depending on where your community of practice is, knowing where your local burn center is, as a group of providers, knowing somebody you can contact there, and even like sending a picture of the burn to ask that question before actually committing the person to going to an emergency department, to getting all worked up, when really it's probably just a follow-up appointment. So it's kind of use your common sense and to think like, how severe or dangerous can this burn be when looking at criteria like we just shown before, because there's a lot of leeway there, and just making sure that you're ensuring the patient has adequate follow-up in a reasonable time frame and understands the risks of having this burn kind of exposed.
Absolutely. And your burn center, very often, don't call them on every burn, right? If it's something you can easily manage, but if it's one of those that you're a little worried, they're usually very happy to triage it with you over the phone. So you can call the burn center and then they'll discuss, do they need to be referred on and something. So that is a resource. But now I want to ask you, what do you do with the blister, right? Because the blister is always like, what do we do with the blister?
Yeah, absolutely. I think this is like an age-old debated question. There's an amazing review article on the Journal of Urgent Care Medicine's website that kind of goes through the literature from 1940 to present day. People have oscillated back and forth what to do with blisters. Here's my take, my 50,000-foot summary. The skin is a natural barrier. 99% of the time, blisters are going to be really helpful in order to protect the underlying skin that is damaged. It's far better than any unnatural artificial Band-Aid that we can apply, outside of a few instances. We've all had a really painful blister on our foot, on our palms, a functional place, that it just feels better if you drain that and there's not as much tension. We talked about severe joint burns needing to get evaluated somewhere else. I think it's also reasonable to drain those because those are really painful when we're moving them around. But I'm not totally de-roofing these blisters. I'm not totally taking them apart unless there's a reason to explore the underlying burn, and that skin that's overlying the blister is preventing me from getting adequate visualization. What do you do with these things?
I agree entirely with you, right? Because I was taught the same. It's a biological dressing, but if it's giant, right, if it's a huge thing, right, or it's going to rupture on its own, you might as well do it in somewhat of a controlled setting. But as you correctly said, some of them, because again, if you go into a deep partial thickness, they can have almost like exudate. It's like a yellowing. And if you were to unroof that, you might even see a degree of third degree burn that might be in there. So there are occasions to do it. But then, all right, so we've done all this. I guess now we're going to send them home.
Yeah, well, but even before we start dressing them up and getting them out of the kitchen, the way that I like to explore these blisters, you could just take like an 18 gauge needle and put it on a 10 cc syringe so that you can have it a little bit more maneuverable and just make a small poke. Some people will take an iris scissor, make a small cut by holding the blister up to make a window if you want to explore and see what's in there without totally unroofing the blister. I've seen a few other techniques, but I think those are probably the safest ones.
I agree. We do that very often with rattlesnake envenomations. We'll actually use scissors. With these, I do what you do. I just use a needle and syringe and get them, and just decompress it.
Yeah, Yeah. So you said, what do we do next? How do we get them out of here? I think for me, the most important thing to realize is like 99% of the time in the place that you work, you're going to have a pack of 4x4s that looks something like this, a very dry dressing. You put dry dressing on some underlying burned skin that's going to be oozing. It's just going to be adhesive, and God, those dressing changes are so painful, even on the smallest of blisters. So what do you put on there to make sure that that dressing stays non-adherent?
Yeah, and remember, you're going to be removing away good tissue too when you're taking that as healing tissue. So the key is, what I will use is bacitracin. You can use polysporin, which is polymyxin, and bacitracin. Triple antibiotic, which also has neomycin, I generally don't like because some people have a reaction, sort of an allergic reaction or a dermal reaction to the neomycin. But really, any of those, you want to keep it covered. It's really not the antimicrobial effects of this. It's just to keep it, as you said, so the dressing, particularly these dry dressings, are non-adherent, and then just a little Curl-X or something over that.
Totally, and something that's oil-based is also very helpful. Like all the antibiotic ointments are, so that it's non-evaporative and lasts a little bit longer. And you can also recommend patients once they leave the urgent care, if they're going to buy like bandages or dressings out at CVS or whatever pharmacy they go to, they make non-adherent dressings that have some coating that's on them that's generally like Vaseline or other oil-based to prevent that problem when they rip it off.
Absolutely.
Topical antibiotics, great. We're not doing it for the actual antimicrobial effect, but to help with the wound healing and also to not have that dressing so painful when it comes off. What about prophylactic oral antibiotics?
There is no role for prophylactic antibiotics. Remember, the skin is a barrier against infection bacteria, but it is not necessary. Do not prescribe, please, systemic antibiotics.
I love it. So let's summarize it for him, Sean. We're going to put them under cold water, get things clean. That sulfadiazine, throw it out. 3-pointer, get it out of your shop, right? We're going to go ahead and consider de-roofing very large blisters, or at least kind of cutting in there to drain them under high pressure areas. And then we're going to give a really nice dressing for them to go home with. We're going to either provide a antibiotic ointment of some kind or a non-adherent dressing, and then tell them to follow up as appropriate for the area of burn, right? If it's in a high-risk place, they can be referred to their nearest burn center. If it's, a little blister on the hand, some small thing on the palm, it's great. It'll heal at home. You never have to come back.
I can't agree more. And Scott, I've never done this on wound care clinic, but I'm giving a double bam. Bam!
Double bam.
There you go.
Right there. All right, we're going to go to the procedure of the month now. We hyped it before with this dental pain. We're going to throw it and learn something new.
All right, everyone, procedure of the month. We've talked so much about dental infections, abscess, too much Halloween candy. So we're finally going to get to the procedure of the month, which is dental blocks. Dental blocks are a really great way to provide pain control for painful dental procedures or even some facial lacerations. So before we dive into these blocks, let's talk about what supplies we need to get, okay? Super basic here, really nothing too complicated. You're gonna get some Q-tips, some gauze. We'll talk about how we're gonna use those in a little bit. Some viscous lidocaine. You can use a 5 or 10 cc syringe, whichever one you want. 25 or 27 gauge needle. This is a 27 gauge needle. Again, doesn't really matter. And then I have bupivacaine here. I personally prefer bupivacaine because especially for painful dental procedures and just toothaches in general, you want that to be as numb for as long as possible. You can use lidocaine. That's totally fine. I just prefer bupivacaine because it's gonna last a little bit longer. All right, so to talk about our first dental block, I am going to use Dr. Jess Mason and her face. Our first block is going to be the infraorbital nerve block. Now, as you can see on Dr. Jess Mason's face, the infraorbital nerve is really going to give our sensory innervation to the skin below the eyelid. It's going to go down the anterior cheek, the medial aspect of the nose, and then to the upper lip, that ipsilateral side of the upper lip. Now, when we look into the mouth, we are also going to see that this is going to get the lip, the inside of the lip, and then the gums on that side. Again, the teeth, the upper teeth on that ipsilateral side. Now, this procedure can definitely be used for painful dental procedures, but one of the things I really like this block for is lip lacerations, especially those that involve the vermilion border. The vermilion border, right, this is already a really complicated one because we want to get good approximation of the lip edges to have a beautiful cosmetic outcome. If I go ahead and inject a bunch of local lidocaine or bupivacaine right into that wound, we're going to start getting tissue swelling, and it's going to be more difficult to line the edges of the lip up nicely. So what we can use for this particular procedure is one of these, the infraorbital nerve block. Now, before we do the block, we need to know where this nerve is and where it comes out. So to use our friend Skelly here, the infraorbital foramen is located right here on Skelly. You see it's on the infraorbital rim, and if you have the patient look straight ahead, you're going to go just straight down from the pupil, and then that's exactly where it's going to intersect on the infraorbital rib, and right there is your foramen. Now, you can inject directly kind of into that area of the foramen, but a lot of us prefer the intraoral approach. Now, to do this, it's going to be nice to numb this lip up and this area up before we go stabbing a needle into the mouth. So all you're going to do is you're going to pull the lip forward. You're going to take that gauze that we gathered before, dip it into the viscous lidocaine, and then insert that just in between the teeth and the lips to numb up that area. Now, to do this injection, as you can see here, the provider has pulled the lip forward and inserted the needle. We're going to insert the needle about 2 to 3 centimeters, aiming up towards that infraorbital foramen. Now, in this picture, you can also see that the provider has their index finger right over where that infraorbital foramen should be. You want to be careful here because some people have some thinner cheeks. You don't want to get the needle to go straight through the skin and actually poke your finger. So be careful when you do that, but putting your finger there can be helpful in directing where your needle is going to go for this block. All right. For our next block, as you can see on Dr. Jess Mason's face, we have the mental nerve block. This is going to provide sensory innervation to the chin and then the lower lip, again on that ipsilateral side. Now, when we look inside the mouth, we see that, again, we're going to get the lip inside of the lip and then the gums on those front bottom teeth, again, on the ipsilateral side of our block. Now, again, to know where we do this block, we need to know where the nerve is, and we're going to use Skelly for that. So as you can see on Skelly, that mental nerve foramen, that mental foramen is located at the second premolar tooth. Now, if you don't know where the second premolar tooth is, because I can barely remember even how to say it, it's the 5th tooth back. So all you have to do is count back 5 teeth, then go straight down, and that's exactly where your mental foramen is located. So again, you can inject straight into that skin, or we can go ahead and do the intraoral block, which is usually what most of us prefer to do. Again, take your gauze, get some viscous lidocaine, pull that lip forward, insert the gauze there, let it rest for a couple minutes to numb up this area, because sticking needles into lips and mouths, it's just really, really painful. So make sure we get a nice, good lidocaine block here locally before we do our injection. As you can see, we're going to pull the lip forward. You're going to insert the needle at about a 45-degree angle to the teeth. And then this, you don't have to go down too far. You have to insert the needle about 1 to 2 centimeters. You're going to inject about 2 to 3 mLs of bupivacaine. Remember, bupivacaine takes a little bit longer than lidocaine to work, so give it a few minutes to do its magic. And then you can go ahead and do whatever dental procedure or laceration repair you need to do. All right, our third and final block is going to be our inferior alveolar block. Now, the mental nerve is actually a branch of the inferior alveolar nerve. So you can see that there's a lot of overlap here in these 2 nerve blocks. Now, I will say anecdotally from experience that when I do the mental nerve block, it's much better at getting the gums numbed up on the front of the mouth. And I feel like the inferior alveolar nerve block really works best for those back molars. Now, to do this, we have to know where to insert. And this is a little bit trickier than our prior 2 blocks. You're going to insert your needle into the pterygomandibular triangle. Now, the sides of the pterygomandibular triangle are the coronoid notch laterally, and then medially is the pterygomandibular fold. Now, if I just said a bunch of words that you do not remember from anatomy, you are not alone, because I had to learn those before this presentation. What you really need to do is, and you're all at home, please join me, take your finger and stick it in your mouth. You're going to stick it in your mouth right between the top and bottom teeth. And right in between there, you can feel this notch. You can feel the coronoid notch on the lateral aspect, the pterygomandibular fold more medially, and then there's this nice groove right between those two areas. That is exactly where you're going to be inserting your needle. Now here's a great example. I personally would take that protective cap off from the base of the syringe just because there's not a lot of real estate in this area. So taking that off will give you a little bit of an easier ability to visualize exactly where that needle is going. You're going to insert the needle about 1 to 2 centimeters. Now again, you don't have to go very far for this one, and you actually should hit bone. If you don't hit bone, you're probably just a little too lateral and may actually be injecting into the parotid gland, which isn't necessarily dangerous, but you're not going to get the block you want. All right, so that is it for dental blocks. Great way to do some of those dental abscessy procedures, facial lacerations, really helpful. Gives a lot of great pain control, and I prefer bupivacaine so you can really get good pain control for a little bit longer. So our next segment, we are going to move on to ENT Brief Cases.
All right, welcome back. We're into briefcases, ENT,
ENT and beyond.
Guess I should have done the Buzz Aldrin costume for this, but it's okay.
For Buzz Lightyear.
Buzz Lightyear, same guy, both went to the moon. It's all good. But before we jump into the cases, we've got our actual trivia question of the evening. I know you guys have been lighting up the chat over the Mike and Gita costume debacle. Josh, why don't you tell us what is our trivia question for this evening?
Well, because this is my first invite to
Yeah.
UC Max Live,
Woohoo!
and I am a bit of a Jeopardy fan, to say the least, I wanted to do a classic Jeopardy question and also keep thematically with what we're doing tonight, which is Halloween. So keep that in mind. So before and after is where the middle word of two different things overlaps. So if I said to you something like, this was an Ice Age predator that also was the youngest person to ever win the Masters, you might say,
Wooly McElroy. Just kidding.
you would think that right on any level.
Oh, sorry.
Saber-tooth
Tiger Woods.
There you go.
All right, I got it.
So, in that vein, this is a before and after question, somewhat related to Halloween. So this lycanthropic mythical creature who suffers from a pre-excitation cardiac conduction disorder better watch out if there's a full moon and he has AFib.
So again, remember this, whoever answers first, fastest in the chat, you get a set of AirPods.
And with that, I think we are ready for story time, which is our brief cases for tonight.
Let's do it.
So, keeping with Halloween, we are in the time of year where people are putting on masks, but this is about the first few cases about taking people's masks off. So this gentleman is a 48-year-old guy I saw in urgent care. He had 3 days of a pretty severe headache. He said it was burning on the left side of his head, but otherwise had a totally normal exam, no neurodeficits, he wasn't vomiting. The reason he was most concerned is because he had had a subarachnoid hemorrhage and had an embolization 10 years ago, so every headache was alarming to him, understandably. But before I jumped to the idea that I needed to send this patient to the emergency department because, oh man, maybe this is his subarachnoid or the aneurysm recurring, I took upon myself to remove the mask and I found something that looked a little bit like this.
Thank God.
Yes, for him
Because
and me.
I was very worried. You're telling me somebody has a headache, they have a coiled aneurysm. It can only be badness. And this isn't great, but I'm feeling much better.
I do love those cases where it's like, oh, this is a simple headache, but by the way, I've had 3 brain bleeds. And you're like, oh, cool.
All right. Cool story.
Could win a pickup with 10 minutes left in your shift.
Yeah.
So, what are we seeing here?
This is great. I mean, I see a vesicular eruption, right, that is extending over to the tip of the nose. And I, as you guys know, am a huge neurology nerd. And I think this is a great example of why neurology is the coolest part of medicine, because if you know a few physical exam things, if you remember your dermatome person, it just goes miles and miles. So this is Hutchinson's sign, right? So this is somebody who has a VZV infection that is of the V1, the first branch of the maxillary nerve. It actually extends to the nasociliary nerve. So we know that affects the exact same part of the nerve that's going to cover the eye, because that innervation only occurs in one other place, and that's on the tip of the nose. So if you see this on physical exam, you know exactly what cranial nerve is affected. I think that's so cool.
My God, you got really excited about that.
It's one of those things, you see it and you know, like, this is the anatomy. This is the only thing that's possible.
But what's really important here is, I mean, so I said thank God, because it's better than a brain bleed, but he's still not out of the woods, because there's a lot of complications that we can get from this. So it's really great that we see the rash on the nose. We know that this is definitely looking like a zoster. But the big thing is we need to do an eye exam, which might be part of the reason that he has a headache. You know, sometimes headaches, glaucoma, corneal abrasions, we got to think of eye things. And so what's really important in this patient is to do a good eye exam. And if you don't have a slit lamp, if you don't, you don't need any of the fancy things here. You really need fluorescein and a wood lamp, because we've got to look for any dendritic lesions, and they're going to be pretty obvious. It's this very particular kind of ferning. It looks very different than a corneal abrasion, and this is a big complication of our zoster patient.
Absolutely, and this is what it might look like. And if you do see that Hutchinson sign, they have a much higher risk than shingles anywhere else on the face of the ocular involvement. So, Dr. Nort, what would we do if we found this in terms of treating this patient?
So there's a couple of things. They need antivirals, and it's AFV, America's Funniest Videos. So those are your choices: acyclovir, famciclovir, or valacyclovir. So acyclovir is the least expensive, 800 milligrams, but you have to do it 5 times a day. They're all for 10 days of therapy. The other one's famciclovir, that's 500 milligrams every 8 hours, or valacyclovir, which is 1,000 milligrams. So that's really important. Ideally, you want to start it within 72 hours of onset. Now, very often these patients will have pain before they have any vesicles. The other thing that I often do is I will add on prednisone. It is very debatable. There is not great literature to support it, but many of us, if not all of us, have seen postherpetic neuralgia, and it is horrible, particularly if it's an older patient. So if there's not a contraindication for prednisone, I'll usually put them on 40 to 60 for a 5-day burst therapy. The steroids that you do not want to do are topical into the eye or ophthalmic. It can make that ferning pattern a nightmare. So please, I would try to avoid anything other than if you want to give them a little bit of something, maybe proparacaine if they had some pain just while they're in the urgent care, and then they can, of course, do their ophthalmic follow-up.
Another good tip, too, is if you don't even have access to a Woods lamp, if they get pain relief on the cornea from just a topical anesthetic applied to the eye, the chance that there is actually a lesion on the cornea skyrockets. And there's a lot of literature, even in sites that do have slit lamps looking at corneal abrasions, that the response to topical analgesia or anesthesia of the eye is at times more predictive than what we can even see on the best instrument we have available. So if you're out there and you're thinking, I don't have a wood lamp, I don't have like a cobalt blue light, but I do have proparacaine sitting around, like, and you see Hutchinson's sign, like, you're very concerned.
Absolutely.
And I think this might be next, what's the evidence? Because I don't know if there's a ton of evidence for those oral systemic steroids. I definitely give them. I think there's not a ton of downside. I mean, of course, if there's some type of contraindication or wildly uncontrolled diabetic, yeah, sure, prednisone's probably not going to be a great idea for them. But in general, I'm with you, Sean. I usually do about 5 days of steroids.
And it can provide a little bit of pain relief, right? So I really don't think you're doing any harm, whether you're doing any benefit for the down the road postherpetic neuralgia. But again, I do it, but I think you will get some pain relief from just the anti-inflammatory properties of it as well.
Awesome. Briefcase number 2.
Let's do it.
So another patient coming in masked, and again, a situation where the mask revelation is clutch for figuring out what's going on with this patient. So this is a 58-year-old woman who came in for 3 days of gradual onset of right-sided facial pain. Now, she had a history of trigeminal neuralgia, and her reason for coming in to see me was that she just needed a refill of her medication for trigeminal neuralgia because she was certain that it was just coming back. She had pain on the same side of her face. But then, lo and behold, we ask her kindly to remove her mask, and we see her face looks a little odd, maybe a bit swollen. So maybe we can go around the horn again and talk about differential for when a patient may have some painful swelling on the side of their face.
Yeah, I mean, this is wide open. I'm glad that this history is not like lightning shooting pain down the jaw, because trigeminal neuralgia is just horrible. And this doesn't sound like that, which is great. Like, this could be anything, Britt, from like losing a fight over Halloween candy and getting socked in the face to a dental abscess, like we've been talking about. We see a lot of swelling that's happening there, and we really need to do a really good look inside of the mouth and explore the parotid gland. I want to know if it's on both sides of the face.
Definitely.
Those kind of things. What's going through your
Yeah,
mind?
I think, you know, it would be really odd, but if it's symmetric and bilateral, mumps has to be on the differential. Again, that would be very odd, but I think we've all seen at least one case of that. But this, I think we're saying it's unilateral, it's painful, might look a little erythematous. I'm definitely thinking something more infectious. I would want to do, again, a good exam to feel the submandibular space, make sure that there's no brawny swelling and induration, because then we're concerned about a Ludwig's infection. This looks more like the parotid gland to me, though.
Yeah, it definitely looks like a case of parotitis. It's a little forward, but again, like it could be the angle that the patient's, you know, just sitting at.
I'm glad you guys agree, because that's the conclusion I came to, and that is just one type of salivary gland infection. But it's actually not the most common. The most common is the submandibular gland infections. And Sean, what are you seeing in this photo here?
So what this is actually, this is eponym. Like, you love it, don't you? This is Wharton's duct. So this is under the sublingual. That's a duct that we see, but it looks like there's a stone there. And that's very often for any of these, right? So this could be sialolithiasis, a stone blocking those, and then with the consequential sialoadenitis. And what we worry most about is, could it be suppurative or infected? And then so very often you want to cover these patients with antibiotic. Now, if it's true parotitis, very often that's viral. But if you see any pus, of course, we would recommend covering with antibiotics.
And I love that we've gone through this segment without trying to say sialodenitis yet.
I can't say that word.
I don't think that's even the right way of saying it.
I'm avoiding that word.
But my favorite thing is this is one of the prescriptions for that. Some nice candy, right? Some,
But not that candy.
Not this candy. We don't have any lemon drops. Sour, sweet stuff.
I don't even know where you get lemon heads at this point, but lemon head, something sour, because you want to express that gland, that duct, and basically get this stone out of there. Sean, I have a question for you. I mean, usually my go-to is Augmentin. Is that the right choice if you think this is infected?
It is. So there's a couple of things. So I agree. And if they don't, you can do lemon wedges. They can do like vitamin C lozenges, right? If they can't find it, just something, as you said, because you really want to increase the salivary flow. Who gets this? People with xerostoma and Sjogren's. I mean, they are people who get this. If you see the stone, try to massage it, try to get it out. And if you see any pus coming out, ideally if you can culture it, because that might change the antibiotic. But I agree. Amoxicillin clavulanate is the first choice of antibiotic. If not, you could use clindamycin. And if you can send the culture, you might have to add something on, so a fluoroquinolone, because sometimes they're polymicrobial. But generally, you're looking at about 7 to 10 days of antibiotics for this with the sialagogues to increase that salivary flow.
I didn't think we'd have to say that one either, but
there are some words in this one.
And this is important that this patients need to follow up with an ENT, right? Because patients often in urgent care, when they have this, it's usually a mild case, but people can get systemically ill. And if they are systemically ill, meaning they have a fever with this presentation, it would be a direct trip to the emergency department for my practice. All right, last case. So this is quasi Halloween related. I suppose this is a 70-year-old man that was chomping on whatever your favorite hard candy is that damaged his crown. Stops off at the local dentist that's a few doors down from our urgent care. And he is getting some work done, and lo and behold, his crown pops off and something happens. It goes down his throat, is what he tells me. So he just pops out of the dentist clinic and comes over to our urgent care. And now he's sitting in front of me without a crown and saying it went down his throat. So in this kind of a situation, what do you want to know first?
I want to know a lot of things, because down throat, the airway, I mean, it sounds like he's talking to you and he's stable. So it sounds like there's no like big airway compromise right now. But like, is he drooling? Is he sitting in a position? Is there pain in the chest? I mean, also, what is this made of? Because once I go trying to x-ray it, like, am I going to find it on an x-ray? So those are some of the big questions I would want to know right off the bat.
Totally. And in addition to what it's made of, like, I would like to look in the mouth and see what it has left behind. Because if you have like a porcelain crown that cracks, it could be sharp and there might be a jagged edge or something there. But sometimes the nice gold ones, you can see it's come off in one piece and get an idea of like what kind of puncture damage could this thing cause wherever it's ended up.
Yep.
Yeah, those are all the right points. And thankfully, it was a gold crown. So this is actually the patient's x-ray here, and you can see it. sitting in the area below the diaphragm, so that tells me that it's not in the esophagus. It's actually in the stomach. You can even see a bit of a gastric bubble there, so that's reassuring. You do want to get imaging all the way from the neck down to wherever you might see it, because not only can you have pneumomediastinum, you can have free air under the diaphragm, you can have a bowel obstruction, it can be in one of the bronchi. So you really want to find it, or at least make sure that you don't see it if it's something that may not be radiopaque. And then the question is, okay, so it's in his stomach, what do we do now?
So it really depends, right? If it gets past, well, it's in the stomach, but if this is not sharp, you should feel comfortable letting it just kind of move through. I would think of this one, I mean, sharp is in kind of almost in the eye of the beholder, right? This is not a razor blade, this is not glass, but I was using the example of like an apricot kernel, right? It has a little bit of sharp edges, but if someone said, hey, I swallowed an apricot kernel, you're not going to refer them on. Importantly, as you said, you want to look, particularly we're talking about a crown here, but if it was magnets, remember the things we worry about magnets with kids is very often there's more than one, and then they can compress and they can cause necrotic bowel. So you really want to all the way down, right, to see the extent of it. But if it's there, it should pass, and you just can either have them just serially follow their stool, or sometimes if you feel a little conservative, you can bring them back in a day or two and just make sure that's moving through the gastrointestinal tract. That's a very reasonable approach with these patients.
Yeah, totally. And we put up here the dimensions of like what the literature suggests are likely to pass versus not likely to pass. So if you're seeing something that's clearly larger than 3 by 6 centimeters, that's very unlikely to pass. And we also have to think about the fact that if it passes beyond the duodenum, it's not going to be accessible by scope. So some things that Sean mentioned that we might want to consider for needing an urgent versus an emergent scope is if it's something that is a magnet or a battery, that needs to come out as soon as possible while it can be retrieved. Hopefully. And then things in the stomach usually can be followed, especially like this patient's crown. And I'm not sure if he ever found it or not, but I did see that he had one follow-up x-ray and it did seem to be further along in the GI tract. So it was doing its thing.
Beginning of the gold rush.
Yes.
Panning for gold, looking for it.
So that's our brief cases, and it brings us to, I guess, the answer for our trivia question. So, I don't know.
What's this before and after? What is it?
The answer is, what is werewolf Parkinson white?
Okay.
So, werewolf being the lycanthrope and wolf Parkinson white being what we have here is the image of a pre-excitation syndrome. And the AFib comment there was, this is really not terribly a dangerous disorder in most cases, except in when patients develop AFib and they no longer have that protective AV node. And this image is actually the EKG from the original publication in 1930. So I don't know if we had any winners, but if not, I'll just do something more simple next time.
I love this. I also
love
love that you have this original paper. First off, let's look 1933, the quality of a medical image that you could get published. You know, I feel like they just drew this on a napkin. That's our understanding of this condition, and that's what we have to
But let's really point out what we see here, right?
Yeah.
That pre-excitation pathway, we see that on our EKG with that delta wave. It's that upslurring of the QRS complex. It gives us a slightly widened QRS. And this in and of itself, if somebody comes in with that, like they probably look fine. They probably are asymptomatic. But once they go into one of these circuits, as you can see in the image, then we get our really fast tachycardia, sometimes a wide complex, sometimes a narrow complex, but that's when they become symptomatic.
Yeah, and I've had some cardiologists like that we've talked to over the time at County, like when do you get really excited about this delta wave in that PR interval? It's certainly like less than 110, less than 100 milliseconds, you know, because you can see some patients that come in, you're like, is that a delta?
Right.
Because it's not always present for people that have it. So just know that once you get into that like sub 120 millisecond time period, sub 110, like they'll get excited that could be what you're dealing with.
All right. So that was a tricky question. Also, one of the other questions that Scott had asked, what are Gita and Mike dressed up as? Gita is Ken.
Okay. The blonde hair.
The
I
blonde
get it.
hair and the bandana. You know, I'm going to be honest. I didn't see the Barbie movie. Maybe I'm like the only person. But she's Ken.
Good.
And what I don't really know what Mike was, to be honest.
Mike was Sideshow
Sideshow
Bob.
Bob.
Sideshow
Right?
Bob.
The Simpsons.
Bob Terwilliger.
Yeah. Oh, great wig.
All right, so people were pretty active in the chat. That's awesome. I want to get to some of those questions. One of the questions that came up was, I'm going to direct to Sean. For the question about hives, the first generation versus second generation antihistamines, is one better than the other? Obviously, one's more sedating than the other, but is one more effective in terms of the treating the symptoms?
So you can think of them pretty much as being very similarly efficacious. However, the rule of thumb with pharmacology is the more side effects, the more effective. So the first generations, and you correctly said, it's the antihistamine effects that's doing anything with this, right? And it's really for the pruritus. So diphenhydramine and other first generations generally work better than the second generations, which are less sedating. But again, do you want someone who's super sleepy if they have to drive or whatever else? So again, it's a case per case basis. But in general, diphenhydramine works a little bit better for the indication that we're talking about.
Perfect. All right, Josh, next question is for you. We mentioned steroids, dexamethasone for migraines. Could you review for us why that's helpful?
This would be nice to have some warning about this, but
Can you do a comprehensive literature
I'd like
review?
a whole lecture, 20 minutes, go.
no, it's a fair question, and I think it's poorly understood because the pathophysiology of migraine is still debated, actually, but it seems to be a vasospastic phenomenon more than a neurologic phenomenon. And so there's the anti-inflammatory properties of steroids, and that's what we see with we're using them for allergic reactions, is that the steroid effects, we don't see them immediately, we see them hours later. So I would say that's something we're more sure about, is that the effects are going to be delayed because it's a steroid effect and immunosuppressing.
Right, and again, you were adding that to your migraine cocktail, not to treat the pain at the moment, but more to help prevent migraines and this pain going on for days.
Exactly. So you don't expect that you're going to get
Immediate
more
relief.
relief from
Right.
adding that. It's more that you're doing the patient a service because you're helping them have the headache stay away for longer.
Right.
I think it's so fascinating too. I know that you certainly have experience in the palliative care world, like where you see steroids oftentimes added in an analgesic regimen later on. And for something that we have such a clear biomolecular understanding of how like glucocorticoids work in the nucleus, like some of these things, it's kind of like the dirty drug benefit that we get that we don't have a full understanding as to why, but for some people it's really helpful.
Yeah.
And again, I want to highlight that you had mentioned oral is just as effective as IV. So.
Right. Or IM or any route of administration is going to be equally effective because timing of onset is not really a factor here.
Perfect. Okay, I want to open this up to the group, but I feel like I have like a personal attachment to this question for some reason, and I don't really know why. But Toradol, 30, 60, honestly, I usually almost always give 15. My understanding in my practice and what I've seen in patients is that it doesn't, the more you give, there's no added benefit, except if you really are angry at the patient's kidneys. I mean, this does affect their kidneys. You have to be cautious, especially in older people. But I've seen a lot of people giving doses of 60, and that just seems outrageous to me. I don't think there's any benefit to that at all.
I have I'm trying to
no.
a very hot take on this, which I love.
We feel passionate about
I think
this
there's
one.
like two levels of this question, right? I think the first level is like the dosage of Toradol. I think we're all gonna kind of maybe agree on this. For me, like I've never given anything more than 15, and now with recent literature showing 10,
10, yeah.
I shoot from the hip at 10. I think the question for me is intramuscular / IV versus just a PO medication. Since we know there's data, right, that it's just as efficacious as ibuprofen, like 400, 600. I forget what the actual study showed. And then I feel like we kind of get into this space, at least in my mind, of like, what are we doing when we're treating pain? Are we also treating the psychological pain and effect that's happening? And so can we lean into a little bit of a placebo effect that we know, like, hey, you're getting a needle, that's not something you can get over the counter, and that gives the patient the psychological relief of pain
It must
too?
be better. It must work faster. It's a shot.
And I'm from the school of thought that, like, yeah, there's some risks with giving IM medications. There's some maybe increased costs and things, but like medicine's hard enough as it is. And if there's like a little side benefit to helping somebody psychologically,
placebo
I
effect.
lean into it. But I'd love to hear how you guys practice.
Yeah, I thought we were going to Squid Game over who'd get to like tear down Ketorolac more. This is not one that I'm dying on a sword about IM, right? Urgent care setting, give it IM.
Yeah.
I am going to say do not give more than 10 milligrams, or if you want to give 15, fine, I'll meet you in the middle. There is no reason to give more. And it is not intravenous or parenteral ibuprofen or something else. It is very potent. You can think of it very much like diclofenac and other different nonsteroidals that have a lot of side effects. And there's been, like, ask a toxicologist anything, I'll always give you some bad case. But you can even get acute papillary necrosis from 1 or 2 doses of ketorolac. That doesn't generally happen with ibuprofen or other things. So use it, but use it appropriately. 10 milligrams, 15. You do not have to give 30. Whether it's IM or not, you do not have to go that high. And definitely not 60. 60 is off the charts, in my opinion.
I really will. In the this month, I have seen people give 60 twice, which is just like, I don't know if some paper came out that was like pushing for more recently, but I really never give more than 15.
It's a problem with the vial size too. So the vials that the urgent cares usually carry is 60 milligrams. And so you end up having to waste 3/4 of it, but yeah, it's the right thing to do because it's not just the kidneys, it's all the side effects of NSAIDs that are amplified, and it's just not one of the safer NSAIDs. But if you're seeing 50 patients a day, this is not the hill I'm gonna die on to argue about if I'm getting an injection of ketorolac or not.
All right. Mel's coming in.
I'm coming into Sean's mic right here. Sean, everybody's asking why ketorolac IV is more the bigger dose than PO. Is there any other drug in the history of the world where you give more IV than you give PO? What the hell is happening, Herbert out?
So that drug is not currently available in the United States, has not, but our Canadian colleagues or people around the world are very familiar with that. Generally, it's just that it's oral. There is no big difference, like when you think about bioavailability or anything like that. That's just the tablet size, because people who are using ketorolac orally, we're using it in this setting, urgent care, 1, maybe 2 doses. That's the indication difference. The people who are using ketorolac for other reasons, osteoarthritis, other types of pain. So it's really the indication where the dose is lower. Just think about ibuprofen. There might be times when you'd use a higher dose of ibuprofen or something, or some other nonsteroidal based on whatever the indication is. But if it's just run-of-the-mill pain, you'll go with lower dose. So that's a great question, and it's one that I've been asked before, but it's not this bizarro, like, reverse bioavailability thing that you won't see. It's really just the indication, the chronicity of use, because they will take that fairly regularly, like anybody would take an oral nonsteroidal.
All right. I think we're going to wrap it up here. I thank you so much to our faculty for joining us, from Josh Russell for being here for the first and hopefully many more to come. Our next show, our next Grand Rounds, remember, it's the first Wednesday of every month. It's going to be our emergency medicine Grand Rounds, and that is November 1st. So again, 5 p.m.
We'll see you there. Links in the doobly-doo. Make sure you like, subscribe, all that fun stuff. And we'll see you at ASAP. You're going to be in Philadelphia. It's going to be great.
It's going to be great. And also, we referenced a ton of literature tonight, probably more than you can keep up with just popping up on the screen. So remember, when this goes up on our HD site on the EMRAP website, all the references will be there in the show notes. They're also in the YouTube channel below. So thank you so much.
Can I do this thing I've always wanted to do?
Oh, my God.
Engage.
All right. See you next time.